competitive session, no question from the audience. Only the judges can.
Okay. Good afternoon all. I am Dr. Manogya Jain, presenting a case of ciliary body mass and scleritis as a feature of pleva. So, a clinical history is 11 years old male presented in our OPD with both eyes redness with a foreign body sensation and photophobia since 6 months. He was treated with topical steroids outside, for which he was of which he was responding well to that part. On asking the past history, he has a history of papillovascular lesions all over the body, and also for him skin biopsy was done, and he was a known case of pleva, which is pityriasis lichenoides at veteruliformis acuta. So on our clinical findings, when we see vision was good, vision was 6.6 for him. The clinical findings on slit lamp examination was shown to a congestion with nodular swelling in both the eyes. There was no tenderness or pain as such, and the posterior stromal opacity was shown with deep superficial vessels and thinning of the cornea peripherally. As you can see, the peripheral corneal thinning is there with deep and superficial vascularization of the cornea and the congestion in the eye. So we diagnosed it to be whether it is a pleva-induced scleral hyperplasia or is it other findings. So we did his ultrasonic biomicroscopy, which showed right-sided diffuse full thickness scleral thickening, which at temporally at the limbus head with a large ciliary body hypoechoic lesion, which was suggestive of ciliary body granuloma. So we were not sure about whether it is because of any infective cause, because there was a tumor, or whether we were suspecting a tuberculosis. So then we done a PET scan for him, which ruled out the metastasis or any tumor present. We also done his AC tap, which revealed only the inflammatory cells and no other atypical cells were shown, and they were negative for any viral infection or any tuberculosis or anything. So then we started him on the topical steroids, and when it was not resolving, so we started the systemic steroids also. We refer him to a rheumatologist and to a dermatologist also, under which he was already going the treatment. So they also started him on the methotrexate for the immunosuppression. On all these medications, he was responding well, and now he is responding well. So what is pleva? Pleva is a dermatological disease, which is pityriasis lichenoides at veteruliformis acuta, which is also known as Mucha-Haberman disease. It is an uncommon cutaneous inflammatory disorder that most frequently affects the young adults and children. Basically, it might be because of atypical immune responses to infections. It can be any inflammatory reactions to the medications, mostly like immunosuppressant medications, or it is a close relation to a lymphoproliferative disorder. So any patient coming with this, we need to rule out any of these things also. So there are only two case studies have been published for this case in pleva involving the ocular involvement. One shows the conjunctival inflammatory nodule in the patients of pleva, and the other was only a conjunctival ulceration. So any pleva, any pityriasis licheniformis ocular involvement is possible. So but they have been rarely reported. So we can conclude that any patient coming with pityriasis licheniformis, any ocular involvement is possible, and for any patient should undergo ocular investigations also, especially if mucosal involvement is present in the patient. The pityriasis licheniformis is an autoimmune in nature, and it strengthens its association with other autoimmune disorders. So ocular examination is also important in patients presenting with the pityriasis licheniformis. So these are my references. Thank you.
Thanks, Dr. Manogya. So you don't have an image of the B scan, right?
Yeah.
And did you do any other investigation to rule out any other possible cause of scleritis and so on?
Yeah, we did all the immunological workup, but he was also a known case of pleva. So immunological workup was done, but all was negative.
So how are you so sure that two different entities
No, so the AC tap, we found only the anti-inflammatory cells, and nothing else we found in the AC tap also.
So AC tap could be showing inflammatory cells in any other cause of uveitis?
No, but we all anti-inflammatory workup, like autoimmune workup, like rheumatoid factor and NCA, we all sent those investigations, which came out to be negative. So that is what we conclude. We are not sure, but that is what we conclude.
Do you have the picture of the UBM?
No picture of the UBM. That was not done in our center, so.
Okay.
Documentation should be there. It's very easy to appreciate.
Thank you.
Nice presentation.
Thank you.
Thank you.
So we'll move on to the next speaker, Atul Sheikh.
Everyone. Today my topic is innovative strategies in ophthalmological examination of candidates during COVID times. So in preface, in the first lockdown after 3 months and second lockdown for 1.5 months, whole India is under lockdown. But in armed forces, the recruitment is still going on, because if there is a halt in this, there is a acute shortage of officers and manpower. So we thought innovation is the only way to win. So how to overcome this COVID examinations, COVID barrier. So I'm going to tell what we have done extra over and above the AIOC's guidelines. So nominal roll of candidates is divided, given by the WhatsApp to the officer, intra-departmental net. An email is given to the department. There is no physical paper is involved. And each candidate is interviewed with the telephonically via WhatsApp video call only, through one WhatsApp video call. For the preparation part, the surgical slide is cut into the two parts, and one part is reserved for only one candidate, and in each candidate it has been replaced. So for stool is be covered with the woman headgear gap, because it has got larger diameter. The doctor is also ready with the whole PPE kit. A prior instruction is given to the all candidates what he has to do inside, what to touch and not what to touch. And you can see this door remains open, so that next candidate can see what is going inside and what he is supposed to do. Hand rest is giving down, so that there is a minimal contact with the refraction chair. And patient has done self visual acuity examination, self installation of dilating drops. We have used two refraction units and refraction trial frames, so that if one is used, it goes to the sodium hypochlorite solution, and it is washed with the normal saline. Again, second one is used for the second thing. A slit lamp examination is done in this manner. What we have done as a slit lamp, face shield as a slit lamp barrier. So this is the small video how it looks like. To use face shield as a slit lamp barrier, first we remove the protective film from either side of the face shield. Now face shield is cleaned with the isopropyl alcohol swab to remove any residual gum and for disinfectant, and is also dried with the clean sterile gauze piece. Next, the elastic band of the face shield on one side is cut, and face shield is molded on the forehead rest. One side of the face shield is tied with the one side of the slit lamp arm, and other side is taped. Now your face shield as a slit lamp barrier is ready. So posterior segmentation installation is done. You can see the both examiner as well as candidates with double masking. Documentation is done. The prior entry is done only on time to save the time, and you can see that it is the candidate form is numbered serially, so that you should not go again and again to touch the fundus photograph imaging system. Last but not the least, the priority of waste material cannot be undermined. There are few problem areas we have faced as a fogging of lens and spectacles that cause a decrease in inaccurate visual acuity recordings, allergic to N95 masks, corrosion of lenses. Goldman deformation tonometry at that time was impossible. Movement of joystick is very difficult if your breast shield is very large, but the show must go on. Thank you.
Thank you, Dr. Singh. You and the entire Defence Forces have our utmost respect for the way you helped us all through the pandemic.
Thank you. Any question, ma'am?
Thanks for the nice presentation.
Thank you.
Thank you.
You have brought out your points very clearly, and that video was very instructive. Thank you.
So we'll move on to Sundara. Over to you, Dr. Sai Sundara.
Good afternoon, everyone. Today I'll be presenting on anti-tubercular treatment in ocular tuberculosis suspects and ophthalmologist accord. There is no conflicts of interest, no financial disclosure, and consent is taken from all patients. TB is the 13th leading cause of the death in the world as per WHO, caused by Mycobacterium tuberculosis. It has both pulmonary as well as extrapulmonary manifestation. Ocular TB includes all forms of intraocular as well as extraocular inflammation due to Mycobacterium tuberculosis infection. Its incidence ranges from 1.4% to 5.74%, even up to 10% in endemic regions. Can affect any ocular tissue, but mostly uveal tissue. TB posterior uveitis, and particularly TB choroiditis, is the commonest manifestation. Tuberculosis screen test, chest X-ray, polymerase chain reaction, interferon gamma release assay, HRCT, and culture are some of the tests that helps in diagnosis. In particular, culture is the gold standard. The objective is to consider ATG in highly clinically suspicious cases of ocular TB. During methodology, all patients of suspected ocular tuberculosis attending the AIOCD were thoroughly examined with these tests. And investigations like CBC, ESR, RBS, urine routine microscopy, viral markers, VDRL, toxoplasma, IgM, tuberculin test, HLA-B27, chest X-ray, and HRCT were performed according to the needs of the patient. It was conducted in the Department of Ophthalmology, Regional Diagnostic Center, Department of Pulmonology, and Department of Radiology. It's a prospective observational study with 1 year period of study. All cases of suspected ocular TB were included. Known cases of TB and those with previous history of ATT were excluded. Out of total of 60 cases, we noted 3 cases of tasitis, 3 as squamous blepharitis, 5 with severe VKC, 2 recurrent tongue-shaped ulcer, and 35 chronic uveitis, 4 vitritis, 5 Eales disease, 2 papillitis, and 1 recurrent pseudotumor. Out of these, the chronic uveitis contribute to 59% of the caseload. So, various phenotypes and difficulty in the insufficiency in sample collection makes definitive diagnosis of ocular TB challenging. So, the diagnosis of presumed ocular TB can be made: 1. Clinical features highly suggestive of TB with positive immunological tests supporting, or any lesion on the chest X-ray or CT scan suggestive of TB. So, the management is just similar to the pulmonary TB. We will be giving rifampicin, isoniazid, pyrazinamide, and ethambutol for 2 months, and then rifampicin and isoniazid for 4 months. Co-treatment with corticosteroids can overcome paradoxical worsening after initiation of ATT. So, my take-home message is start ATT in cases of high clinical suspicion of ocular TB, even if there are no definitive investigations supporting, provided all other possible causes are ruled out. Thank you.
Thank you, Dr. Sai Sunanda. What is the prevalence of TB in your patient population? I mean, in a year, in your, say, medicine OPD, out of the total patients, how many tubercular patients come in?
We do come across a lot, ma'am.
Okay, so if you, if that data was there, this would have been a much stronger presentation, because 35 presumed cases of ocular tuberculosis in a year is very high, even in centers which deal regularly with intraocular infections. So it would help if we have the background that what population we are getting this out of, right? And because it always depends on, we can't blanketly say that whenever we see a patient like this, we are going to suspect ocular tuberculosis, right? What is the likelihood?
Okay. So, whenever we suspect an ocular TB patient, we are, patient should have at least one of the.
But what I'm trying to point out is that it depends on what your patient population is.
Okay.
So the likelihood ratio, that is what we are talking about.
Okay. Thanks.
Now we'll move on to our next speaker, Dr. Shilpa Hembrow. Over to Dr. Shilpa.
Good afternoon, everyone. I am Dr. Shilpa Hembrow, and I will be presenting on incidence of non-traumatic subconjunctival hemorrhage in the tertiary care center of Jharkhand. What is not? subconjunctival hemorrhage is a
Please start the timer.
Restart the time.
Please start the timer. Yes, please.
subconjunctival hemorrhage is a common benign condition of the eye that has characteristic features such as the painless acute appearance of a sharply circumscribed redness of bleeding underneath the conjunctiva in the absence of discharge and inflammation in the contagious area. It is usually not accompanied with decrease in the visual acuity. The incidence of subconjunctival hemorrhage was reported as 2.9% in a study with 8,726 patients, and it increased with age, particularly over 50 years of age. It is thought that this significant increase depends on the increase of prevalence of systemic hypertension after the age of 50 years, also diabetes mellitus, hyperlipidemia, and the use of anticoagulation therapy becomes more frequent with aging. My aim of the study was to determine the incidence of non-traumatic subconjunctival hemorrhage in the tertiary care center of Jharkhand from December 2021 to December 2022. The method was a cohort study. Individuals with the first diagnosis of SCH were identified by corresponding international classification of disease 372.72 traumatic subconjunctival hemorrhage were excluded from the study. All demographic factors, comorbidities present, use of any medications were recorded and studies. Results were a total of 57 patients were identified in the period of 1 year. The incidence of non-traumatic SCH was higher in females than in males. Most common side affected was nasal. Most common comorbidities associated with non-traumatic SCH was hypertension. These are the graphs. From my study, I concluded that SCH can be a sign of serious systemic disorder. Our study was a prospective study, and so regular follow-up of patients was not possible. Traumatic SCH is very common, so it was excluded from the study. Saingolu et al. Reported 32% of cases as having non-traumatic SCH, but they considered traumatic cases in the total sample studies. After 60 years of age, the incidence of anti-SCH was increasing tendency, which may be more probably due to increase in the incidence of systemic disease after the age of 60 years, and also due to increased fragility of vessels. In our study, the highest incidence was found in the age group more than 60 years, which is similar to the study conducted by Yu et al. In our study, the incidence of non-traumatic SCH was more in females, which is similar to the study conducted by Yu et al. And Kaimbo. In a follow-up study of patients having SCH, Wang et al. Reported a significant risk of developing cerebrovascular episode. Anemia was also a systemic factor associated with SCH. In a study of anemia in the rural population of India, Alvarez et al. Has shown anemia to be prevalent in women and older adults, and this reason is in the favor of our study, where SCH is more common in females and in more than 60 years of age. In our study, nasal side was more affected. This could be because of the small area of nasal conjunctiva with crowded conjunctival vessels susceptible to SCH. However, our study result was in contrast to Saingolu et al., who reported temporal conjunctiva as a common site for occurrence of SCH. There was no preponderance of anti-SCH in a particular eye. However, right eye was more commonly affected, which could be just incidental finding. In conclusion, SCH should be evaluated thoroughly, as itself is not a serious condition, but it can be the sign of serious systemic illness. These are my references. Thank you.
How do you determine whether it is non-traumatic?
From the history of the patient.
Sometimes there may be a trivial history of trauma which the patients don't give. Then those patients are included in this group.
Those patients who are not giving proper history, we have excluded them.
Suppose if a patient says that I noticed the red eye once I woke up in the morning, so maybe that patient injured himself with the finger or something at night. So was that included or excluded?
We were excluded.
Excluded. So what was the age distribution of the population of your study? In case you missed that. What is the youngest?
Youngest, it was less than 20 years.
Less than 20 years.
Children 20 years and.
Okay.
Thank you.
Thank you.
Thanks, Dr. Shilpa.
Good afternoon, one and all. I'll be presenting two case series on the acute CSCR in pregnancy, on the update and on the etiology, diagnosis, and management. So, as an introduction, CSCR is an accumulation of subretinal fluid at the macula, which presents as a circumscribed area of serous retinal detachment. Pregnancy being a risk factor because of endogenous hypercortisolism. So the first case details are patient 31-year-old female in second trimester, known case of diabetes, presented with history of blurring of vision in the left eye for 2 days. BCVA in being 6.9 and fundus showing circumscribed area of localized serous detachment at the macula. Diagnosis being confirmed by OCT, we came to the conclusion of CSCR. 4 weeks later, the patient's BCVA was 6 parts, and we could see resolving CSCR with organized subretinal fibrin confirmed by OCT. Second patient, 26-year-old female, again in second trimester of pregnancy, complaining of blurring of vision in the left eye for 1 day. She was just a known case of hypothyroidism. On treatment, we can again see localized area of serous retinal detachment at the macula. BCVA being 6.9, diagnosis was confirmed by OCT. 4 weeks later, we can still see retinal detachment being present. However, it has reduced. 8 weeks later, it has reduced. Patient's vision is 6.6, and some subretinal fibrin accumulation can be seen. Systemic workup for the patients were within normal limits. BP was normal. There was no evidence of proteinuria. FFA was not done since it was an acute presentation, and also as a precautionary measure since the patients were pregnant. Discussion. So coming to the proposed causes for CSCR in pregnancy, hormonal alterations are considered to be the main risk factor. Increased corticosteroids. Also there is increased there is impaired autoregulation of choroidal circulation, which gives rise to alteration of the blood retinal barrier choriocapillaries in RP, leading to increased permeability, precipitating CSCR. Other mechanisms proposed are hemodynamic alterations, decreased colloid osmotic pressure, hypercoagulability, and changes in prostaglandin levels. Clinical course, it most commonly presents in third trimester, since third trimester has the highest cortisol levels. However, in our patients, we noted it to be in second trimester, and it mostly resolves by 4 to 8 weeks postpartum. Subretinal fibrin has been seen associated in 50% of the cases of CSCR in pregnancy, according to literature. Coming to recurrence, the patients have to be warned about the recurrence of CSCR in subsequent pregnancy and to present as early as possible. These are some literature review in which patients present, CSCR was there in the 6th month in first pregnancy, and CSCR recurred again in 6 months in the second pregnancy after 2 years in the same patient. Differential diagnosis, toxemia-induced retinopathy and posterior scleritis can be kept as a differential diagnosis. However, they were ruled out since there were the patients did not have any toxic features, and there was absence of proteinuria. As for posterior scleritis, there was no complaints of pain. The B scan was normal. These are my references. Thank you.
So in these two patients, both of them were having first attack?
Yes, sir. First, they were first pregnancy and first attack.
Nicely documented. So
Thank you.
how are you going to warn them? Are you going to communicate with their obstetrician? What are you going to do when you see such a patient?
Regular BP monitoring was advised, ma'am, first of all, and renal function tests were done. However, the patients improved by 8 weeks presentation ocular wise. However, the patients are still in follow-up with us. They have been advised of about 6 monthly. Now they have delivered and they are doing fine. They have been advised of 6 monthly follow-up with us. Thank you, ma'am.
Today, I'm going to present spontaneous vitreous hemorrhage and subconjunctival hemorrhage and isolated ocular manifestation in thrombocytopenia without any other systemic manifestation. So introductory, that is ITP means it is just antibodies against own platelets which cause peripheral destruction, result in low platelet count. It mostly it can be ophthalmically, very rarely it will occur, and whenever it will occur, it might be bilateral. And hemorrhagic ophthalmic manifestation associated with ITP, it may include Terson's type of phenomena or hemorrhage within optic tract or non-arteritic
or thrombocytopenia alone also, when platelet count is less than 50,000, it is rarely sufficient to cause significant retinal hemorrhage. We represent a case of idiopathic thrombocytopenia presenting as vitreous and subconjunctival hemorrhage as an isolated manifestation. A 55-year-old male presented to our OPD with 20 days history of sudden painful loss of vision, redness and swelling in the right. He took medication from some outside clinic, but it is not cured. So he was alcoholic from 25 years, but no trauma history as per patient. There is no past history of hypertension, diabetic or any other systemic illness, and his general and systemic examination was entirely normal, including all signs of ITP. On ocular examination, right eye showed perception of light, lid edema, conjunctival chemosis, SCH, corneal haze was there, and AC was shallow, NVI was there. IOP, when it measured on inflammation tonometer, it was 36. Fundus examination was limited by vitreous hemorrhage. Left eye, it was completely normal, IOP was normal, and anterior and posterior segment was normal. There was no NVI in left eye. Right eye B scan was suggestive of vitreous hemorrhage with subhyaloid hemorrhage. After few days, patient came with he has few reports like FFA done 4 years back. He had similar history of sudden drop of vision, and then on investigation we did blood investigation. First we did there was platelet count was 8,000. So we referred that case for medicine department for thorough investigation. Their PS study showed normocytic normochromic anemia with no definitive sonological abnormality, and they did even bone marrow biopsy also. So the provisional diagnosis was ITP was kept. On management, we started on anti-glaucoma medication, then eye drops, and under close observation, we kept in ophthalmology. Then blood transfusion was given from medicine side. So chronic thrombocytopenia was considered as a cause of right eye SCH with vitreous hemorrhage with no other bleeding manifestation. So on discussion part, so thrombocytopenia alone, even if severe, it is sufficient to cause significant retinal hemorrhage, and it is association with ITP. It is mostly been reported to occur with concurrent severe anemia. Systemic therapy usually suffices, leading to resolution of hemorrhage with good visual prognosis, and ITP may present with subretinal, preretinal or VH. So, and high index of suspicion along with comprehensive systemic examination and appropriate laboratory workup aids in diagnosing this disease. So in conclusion, the importance of chronic thrombocytopenia, which manifested as retinal reovascularization with vitreous hemorrhage and SCH leading to loss of vision, and of course consider importance of briefing history and thinking about some unusual cause if history does not matches with examination finding. These are my references.
Dr. Sheetal, maybe you would want to go back and revise your diagnosis or revise the heading. You can't, there are a lot more things going on other than only subconj hemorrhage and vitreous hemorrhage. And can you explain in a sentence how thrombocytopenia might lead to neovascularization? Because ultimately the pathology is neovascularization. Just one sentence. How does thrombocytopenia cause neovascularization?
That's what, ma'am. In this case, we thought first about glaucoma including or anything, but left as
glaucoma is secondary to neovascularization. How did the neovascularization come? How did the ischemia occur?
Might be ocular ischemic syndrome, ma'am. So, it is we couldn't find out any cause. That's why we did a blood investigation only. So, ophthalmic side, there was nothing we could make out.
Was the RAPD was positive, or is the RAPD was present?
RAPD was present.
Okay. So what is the cause of I couldn't find what is the cause of the raised IOP. Was the gonioscopy done?
No, sir, we couldn't do gonioscopy because corneal full haze was there and he had severe pain that time also. Even we tried. Just we could take one IOP that time.
So was the patient called back later on follow-up?
On successive follow-up, VH was resolving till after 1 to 2 months, hand movement he got.
Okay, but we still cannot figure out why the IOP is raised, because as you said, the fundus fluorescent angiography showed neovascularization. So one of the probable causes may be neovascularization of the angle or something like that. But was the AC clear? But it was not visible.
No, that time not visible. After follow-up, it was okay.
When the corneal haze cleared, was there blood in the AC? No.
Sorry, sir.
When the corneal haze cleared, was hyphema noted in the AC?
No, sir. It was cleared up actually.
Okay.
all, I will be presenting the role of combined immunomodulators in severe steroid intolerant VKC. So as we all know, VKC is a very common problem in India and often presents with acute episodes. So steroid agents have to be prescribed to control the severe inflammation. However, their long-term use can cause glaucoma and cataract. Steroid-induced raised IOP is seen in 28% of VKC eyes, out of which 5 to 6% develop glaucoma and might need surgery also. So steroid-sparing agents are being investigated. Management in these cases is often difficult and challenging due to fewer options available as well as biological variation of the disease. Both cyclosporin and tacrolimus have been proven to be effective in these eyes. However, due to different mechanism of action, we believe that a combination of these drugs might have a synergistic effect leading to a rapid resolution of inflammation. So we conducted a retrospective study and included all patients who were referred from glaucoma clinic for the management of these patients and could not be started on steroids. They were either responders or had glaucoma and cataract, and patients who had already on immunosuppression were excluded. We included 22 eyes which are steroid responders, 13 had glaucoma and 4 had cataract, 10 patients were male and mean age was 13 years. Out of all, 91% had mixed variant of VKC. And other features were giant papillae, ptosis, pseudogerontoxon, scar and keratoconus. Clinical features were graded according to Muller et al. And these are the images showing the grading of clinical signs. When the patient was referred to us, we first started cyclosporin 0.1% because all were having severe limbal involvement, and olopatadine, lubricants and anti-glaucoma was continued. Then at 2 weeks, if the response was suboptimal, then we added tacrolimus BD for 3 months in tapering dose, which was stopped after that, and cyclosporin was then continued for 6 months. So all patients were evaluated at 2 weeks of combined therapy, then at 1 month, 3 months and 6 months. The mean total subjective and objective score from baseline reduced after starting the treatment, but the change in the total score was much more after the combined therapy. Similarly, in the objective score, percentage of eyes which showed reduction in score from 3 to 1 was increased from 60 to 100% after combined therapy. Thus, the absolute change in the total score was much more. Photophobia and conjunctival hyperemia resolved within 4 weeks and no recurrence was observed till 6 months. These are the images showing resolution. Mild irritation was observed in a few eyes, but medication had not to be stopped. So the reason why we included tacrolimus is that there is a difference in their chemical structure. They have different mechanism of binding to different category of proteins, and tacrolimus has a higher potency pharmacologically. So we evaluated their synergistic effect. The limitations were a small sample size and it was a retrospective trial. So the synergistic effect was effective, and whenever cyclosporin efficacy is suboptimal, we can add tacrolimus to improve the efficacy. However, tacrolimus is still an off-label drug. So we started with cyclosporin as an alternative to steroids. For long-term control, we use cyclosporin itself. Also, the rate of resolution of symptoms, as you all know, is fastest with steroids, and the combined use of both may lead to rapid resolution and control of symptoms with reduced recurrence in cases as compared to only cyclosporin. Thank you.
I'm just curious, if an ophthalmic concentration of tacrolimus is available in India, how is that? I mean, why is that an off-label use?
No, it is not approved by FDA because still this long-term safety is not proven.
I'm talking about, the drug controller India. So
Yes, ma'am.
tacrolimus is available in India in an ophthalmic
But there are some reports that in long term there are some reports of lymphoma if the patients are applying on eyelid skin or something. So that's why we always preferred cyclosporin, and if it is not getting controlled, then we added tacrolimus.
It will take at least 4 weeks to start the action, either of the one. If you have both the CSA, cyclosporin, but if you have the government itself, you have to stagger off the steroid responder if it is to salvage the eye and stem cells. To start with those polyclinic start the steroid. It's good reports on the study. You can give it the synergistic effect on the both the immunomodulator.
Because their action is slightly different, so they
How long you will continue the cyclosporin in? How long?
6 months we continue.
Both 6 months.
No, tacrolimus we stopped at 3 months, and then only cyclosporin, so it was maintained till 6 months.
But it has already been proven that for VKC patient, tacrolimus is much more effective compared to this.
A lot of reports are available, but we just wanted to see the combined effects.
Okay, thank you.
Very good, sir.
Thank you, sir.
Thank you very much, Dr. Dipali. So we'll move on to our next speaker, Dr. Santosh Kumar.
Good afternoon, one and all present here. I'm Dr. Shanmati. I'm here to take you through a rare case of blister beetle-induced keratoconjunctivitis. Keratoconjunctivitis, as such, is an inflammatory condition which would involve conjunctiva, superficial cornea, secondary to viral, bacterial, autoimmune, and other allergic etiologies. Contact with blister beetle, as such, would result in the form of dermatitis, which would manifest as urticaria followed by blister formation due to the toxins released by blister beetle. Keratoconjunctivitis secondary to blister beetle is out of the common disease entity. This case report is presented owing to its uniqueness of being first time reported in India. Here, a 23-year-old patient reported to the OPD with complaints of pain, redness, watering, photophobia, irritation, along with blurring of vision in both the eyes for 2 days. Prior to ocular complaint, she had a history of fall of blister beetle over her right thigh, and there occurred a onset of multiple painful blisters over the right thigh. On further probing, she gave the history of accidental rubbing of the eyes with the fingers contaminated with the blister fluid. This is the hyperpigmented vesiculobullous lesion seen in the supromedial aspect of the right thigh, and the best corrected visual acuity in the right eye was 6 parts, and there was lid edema with circumcorneal congestion, and there was an epithelial defect noted which was extending from 5 to 7 o'clock position in the right eye. And in the left eye, the best corrected visual acuity was 6-9 parts, and there was lid edema with circumcorneal congestion, and there was an epithelial defect which was extending from 5 to 6 o'clock position. Other anterior and the posterior segment examination were normal. As there were epithelial defect in both the eyes, patching of both the eyes was done after antibiotic eye ointment application. And on day 2, the epithelial defect in the left eye healed, whereas on the right eye, the epithelial defect reduced in size with reduction in the congestion. So patching was continued for the right eye after antibiotic eye ointment application, whereas for the left eye, topical antibiotic eye drops, eye ointment along with the lubricants was continued without patching. On day 3, the epithelial defect in both the eyes got healed. On day 4, to reduce the ongoing inflammation, topical low-dose steroids was started for the patient, and in a course of 2 weeks, there was reduction in the inflammation. Blister beetle, which is known as Rovi beetle, is commonly seen in Tanzania, Southern Europe, East Africa, and in some parts of Kerala, more prevalent in the rainy season. Among them, the Nairobi fly is most commonly involved in causing dermatitis due to the toxin released by them, the pedrin. The pedrin toxin will be released by the Nairobi fly only when it's been accidentally touched or crushed. Ocular manifestation usually occurs following the cross-contamination of the eyes with the fingers contaminated with blister fluid, manifesting most commonly in the form of periocular dermatitis, keratoconjunctivitis, filamentary keratitis, epithelial defect, and rarely corneal ulcer. Blister beetle-induced keratoconjunctivitis has a good ocular outcome if timely management and appropriate intervention is done at its earliest. Ocular presentation may mimic with herpes simplex, herpes zoster ophthalmicus, and other allergic contact dermatitis. The characteristic linear lesion not involving the dermatomes, an idea about the epidemiological factor helps in diagnosing the condition. Hope this case would guide us in keeping this etiology in mind while examining a patient with keratoconjunctivitis, especially from an endemic area. Here, these are my references. Thank you.
Thanks, Dr. Shanmati. This is a very interesting case. I would probably ask that you've done a nice documentation, but there are certain conventions of corneal diagrams, including cross sections and so on. There are certain color codings. So maybe in future, if you incorporate that, because those conventions are there for a reason. When you present that, any other ophthalmologist will be able to identify exactly what you're depicting. That's why the conventions are in use. Thanks.
Was there any lag ophthalmos?
No, sir.
Why I'm asking is both the epithelial defect are inferior.
Yes, sir.
So maybe whether the lack of ophthalmos has any contribution to that. That's what I'm asking. Was there a chemosis?
Only lid edema with circumferential epithelial defects.
Okay. Okay.
So we'll
afternoon, everyone. I'm here speaking on a comparative study of tear film changes with teresium and after teresium excision with conjunctival limbal autograft. I have no financial disclosure. Teresium is the most common ocular surface disorder and has been frequently associated with dry eye disease. Global prevalence is 2.3 to 21.3% and reaching higher number in tropical region. The purpose of this study to evaluate tear film and meibomian gland functional changes in patient with teresium and after teresium excision with conjunctival limbal autograft. As we know, teresium can cause symptoms of discomfort, corneal irregularities, induce astigmatism, tear film disturbance, thus compromising visual acuity and patient's quality of the life, as teresium destroy superficial layer of the stroma and Bowman's membrane and also associated with meibomian gland changes and implicate in meibomian gland dysfunction. Here we adopted teresium excision with conjunctival limbal autograft, which was suture and glue-free autologous graft. In this study, this is a interventional comparative study with a population of 55 patients with unilateral grade 2 teresium. Ethical clearance was taken and demographic data were recorded. It was 1 year study duration and it was conducted at the tertiary healthcare center. The tear film changes and dry eye disease assessment was done of all the subjects before and after 1 and 3rd month of the surgical intervention by Ocular Surface Disease Index questionnaire, Schirmer's 1 test, TBUT, TMH scoring and meibomian gland expressibility were recorded. Exclusion criteria were patient with any corneal disease, scar, contact lens user, cicatricial ocular surface disease, ocular allergy, trauma, infectious were excluded. These are then tear film measurement and other parameters were compared before and after teresium excision with conjunctival limbal autograft. And results, age distribution of teresium was maximum 30 to 40 year age, 40 to 50 year age with male preponderance. Schirmer's 1 test value were significant low, less than 10 mm in patient with teresium compared to the teresium excision with conjunctival limbal autograft. Same TBUT were less in teresium patient than post-op patients, and TMH value were also significantly low in pre-op than post-op. The mean value of meibomian scores was statistically significant, and on the discussion part, the study was also, our finding were also supported by other study, as Kim et al. Found TBUT significant improve after conjunctival limbal autograft, and APEC et al. Also compared teresium with teresium healthy control, and he concluded teresium is associated with tear film instability and dry eye disease. Shai et al. Also found a TBUT significant improve in conjunctival autograft. He compared conjunctival autograft versus conjunctival autograft with amniotic membrane, and he found significant improvement in both groups. And same Shrestha et al. Who studied on the bare sclera, he showed deterioration in the tear film stability and its secretion, and an increase in the prevalence of the dry eye disease if we were doing without graft. So limitation of our study were the comparison with other technique. We have not compared the tear film changes after teresium excision with the CLAG, and evolution of tear film cytokines and growth factor were not recorded, and correlation for long-term clinical outcome were missed. So overall, future research in this area can provide valuable information on the mechanism and clinical implication of tear film changes after teresium excision with CLAG, and can guide clinician in selecting the most appropriate treatment option for their study. So I concluded that teresium has a close relationship with tear film in stability and meibomian action, and tear films improve teresium excision with CLAG. Thank you.
Thank you,
These
Dr.
are
Vidya.
references.
Very nicely presented, very nicely done study. Dr. Vidya, what would be your comment on the clinical significance of the study? How badly were the patients affected at the beginning, and how much relief did they get?
It's showing as teresium there is association with a dry eye disease. So if we excise it on the time, we can improve ocular surface health.
Were the patients symptomatic before surgery? How much? And does that come to be clinically significant?
Yes, that's why this study shows that even patient is, if not complaining, even though we should consider for the surgical excision and
If the
the
patient is not complaining, how does it matter?
actually if we see tear film changes, as we have seen this in this study, so there are ocular surface health problem with pterisium, which will ultimately finally this is the one of the cause of the after pterisium excision of the recurrence of pterisium, and visual acuity also disturbed. So I think I prefer to excise on the time with graft.
Excision of pterygium is well taken.
Yeah.
The justification for the excision of pterygium, give me a good proof that yes, it is justified to excise a pterygium in order to treat dry eye disease. How can we make, if a patient is asymptomatic, how can we make that patient feel better? It comes down to that principle of treatment of a patient. Right.
So we can assess tear film changes, maybe gland dysfunction, and if is it there, then we can advise.
So I would say we start off with discomfort index and quality of life.
Yes. Well, thank you.